Welcome to AJP Audio for March 2026. I'm Aaron Van Dorn. Today on the podcast, we have Dyan Gober Dykan, a doctoral student at Tel Aviv University in Israel. Mrs. Dykan and colleagues have a paper in the March issue of the journal looking at the use of attention bias modification as a potential prophylactic treatment for PTSD in combat-bound soldiers. Afterwards, we'll again speak with Dr. Ned Kalin about the rest of the March issue of AJP. Mrs. Dykan, PTSD is a major risk for soldiers who are exposed to combat and is associated with long-lasting physical and mental health comorbidities such as substance use disorders, anxiety, and increased risk of suicide. Your study took a look at the efficacy of two attention bias modification protocols designed to enhance the amount of attention the participants paid towards threatening images as an attempt to prevent PTSD. Let's start with the two arms, one of which used a response time paradigm and the other used a novel eye tracking paradigm called gaze-contingent music reward training.
So both of these paradigms are extensively researched in ABM literature. And the first one, the response time based, was actually what we call kind of the first generation. Now, this is based on a dot probe task where there's first a fixation cross to fixate the participant's gaze in the center of the screen. After that, there are two stimuli, facial stimuli, one negative, meaning angry, and one neutral, above and below where the fixation cross was. Those show up very shortly, and then they're followed by a figure arrowhead. The participant's job is to respond as quickly as possible by pressing the relevant arrow on his or her keyboard, in our case, his keyboard. When we're trying to modify a participant's attention towards angry faces, which we did, towards negative stimuli, which we did in this task, in order to modify their attention towards threat stimuli, we essentially put all of the probes, the arrows, behind the angry faces. So by repetitively doing these 160 trials where the arrowhead always appears behind the negative face, the angry face, and they have to answer as quickly and as accurately as possible, we're training them to look more towards the angry faces. Now, the second generation is the eye tracking base, as you said, the gaze contingent. And this is essentially a more novel, like you said, a more modernized way of testing attention, because instead of testing attention through a behavior that happens at the end of a quick but relatively complex process of attention, we're looking specifically at where their visual attention is. Where is their gaze on the screen? Through each trial, here there are only 30, but at each trial, the participant sees a matrix of 16 faces, obviously counterbalanced, half neutral, half angry, half women, half men. And the participant is looking, he's told to look however he wants. However, before he starts this task, he's given a music menu. A music menu, he gets to decide what music he likes to listen to, what he wants to hear for the duration of the session. And the catch that he does not know until he starts is that whenever he looks where we want him to look, he hears his music. So when he looks at the angry faces, which we want to enforce that type of attentional pattern, looking towards threat, he hears his music. But when he looks towards the neutral faces, his music stops. And this way, we're using conditioning to reinforce the attention towards threat.
So I would assume that between these two different paradigms, there's a significant difference in the response time that you're looking at. With the response time paradigm, I'm assuming it's very quick, on the order of microseconds. Yes. And with the gaze contingent music reward, what kind of response time are we looking at? How long are they looking at these faces, and how long does it take for the music to start playing?
Great question. So we're not examining the response time in the gaze contingent task. We're looking actually at sustained attention in that task. We're looking at how long they're looking at angry faces versus neutral faces. And we see, even after one session, that their tendency to look towards angry faces increases thanks to this music reinforcement. So the music starts right away. As soon as they look at the one of the negative valenced stimuli, the music automatically begins, and as soon as they look away, it starts. It will come back as soon as they look. But again, that's less so what we're looking at that task, because instead of the response time, we're looking at sustained attention. So the stimuli are similar, but the mechanism of attention could be very, very different, which is why we suspect there was a difference between the efficacy.
Well, speaking of that, your findings showed that the response time arm had a significantly greater impact on post-combat PTSD than either the sham arm or the gaze-contingent music reward arm. What do you think accounts for the differences between the two ABM arms?
Great. So like I said, I think we think one of the differences could be related to the slightly different cognitive mechanisms being targeted in these two paradigms. So the response time paradigm is targeting threat detection. How quickly are they going to detect the angry or the threat stimuli, the angry face, as opposed to the neutral one? How quickly are they going to look at that and be prepared to see the probe behind it? On the other hand, you have the gaze-contingent paradigm, where that is based on sustained attention. Again, how long are they looking at one versus the other? And we believe that one possibility for this difference in the results between the two paradigms is that threat detection could be a lot more relevant in the preventive context for combat-bound soldiers, where the mechanism and the environment demands are more aligned. So faster threat detection can facilitate survival, situational awareness, operational readiness, all those things that you need when you're in combat. And it could also be related to more effective processing of traumatic occurrences because of all of those elements, thereby reducing the risk for PTSD. Of course, this is something that we would have to test further, but that's one of the things that we think could contribute, because that's very, very relevant in the context of combat, the threat detection. Another difference, of course, could also be the differences in delivery. So what I didn't mention before is that the response time task is much shorter. It's about 7 minutes as opposed to 12, so it's half the time. Not that 12 is very long, but so it's about half the time. And all it requires is a laptop, even a telephone, a cell phone, just one screen. Whereas the gaze contingent paradigm, it requires a lot more technology. So you need, at the very least, a screen and a camera to be able to. We used an infrared camera that hooked up to the computer, and there was a separate computer as well. It was very hefty technologically. And so it might be less relevant for the context of the military, where they don't have much time to give to very important things like that. And, during the training, with everything that's going on, the soldiers could have been a little less able to sit down and open to sitting down for 12 minutes of looking at faces, as opposed to very quick, on the go, 7-minute program.
Usually when we're looking at PTSD trials, we're looking at things that are working in the aftermath and treating PTSD, whereas your study obviously is more of a prophylactic approach to preventing PTSD. And by its nature, your research obviously involves soldiers going into combat and potentially doing harm to other people. And regardless of the underlying ethical considerations of combat itself, what were the ethical considerations that your group considered in designing this trial?
That's a great question. Wow, war is terrible and raises many ethical and moral dilemmas, obviously. But for us as researchers, the question wasn't about war and combat. Our goal was to reduce PTSD. And that in and of itself is not something that we see as an ethical issue, trying to prevent suffering, kind of the opposite of the ethical issues, of war. And so I would say that's kind of where we saw ourselves regarding that. But one thing I will say, a major consideration, ethical consideration for us, had to do with the fact that our participants were soldiers, and this is a captive audience in a context where they're used to being told what to do, when to do, how to do, not even why to do sometimes. And a very, very critical, pivotal part of research, especially in RCT like this, is that it's voluntary. It's completely voluntary. They cannot be forced or coerced to participate, which is very different than a military setting where they have to do what their commanders tell them. And so we worked very hard with the military to ensure that this type of atmosphere, was understood by the higher ups and the commanders, that it's completely voluntary, that they don't need to, and also to the soldiers to make sure that they knew that participation was 100% voluntary, that there would not be any consequences. They were free to decline participation Commanders were not allowed to be present at all while they were in session. But I also want to, if I can, you also mentioned the fact that most studies focus on treatment and not prevention. And I want to just say that that's one of the things that I loved so much about this study, because as important as treatment is, we can also help reduce the suffering by catching it head on, catching it before it even happens. If we can reduce the amount of people who end up suffering from PTSD and who need the treatment, then we're helping the treatment as well, and the systems that have to provide that treatment.
Absolutely. Did your study control for combat conditions and experiences that the participants saw? Two experiences of combat conditions obviously can't be directly comparable, and so you might have different levels of PTSD and might impact how this prophylactic approach to PTSD prevention might go.
Yeah, absolutely. Even two people who experience the exact same traumatic event can experience it very differently and can react to it very differently. So obviously that part is not something that we could take into control. We cannot control that. But we did take what we could into consideration as best as we could, to the best of our ability. So we did this through both the study design and the statistical analyses. First of all, the randomization of the soldiers into the three arms was done within each platoon, because there are some platoons that end up seeing more action, some platoons that end up having less action. Commanders of the platoons can be very, very different, and this can also affect what they do and how they react and everything in that sense. So it was very important for us to do the randomization within each platoon to control for these differences between platoons. And second, we tracked their combat exposure through a self-report questionnaire that was used in previous studies as well. This is called the Combat Experiences Scale. And essentially, they say what type of combat experiences they were exposed to in their service. And then we were able to use the soldiers' combat exposure scores as a covariate in the statistical analyses. So in both of those ways, we were able to control to the best of our ability the differences in combat conditions.
Your study used 4 sessions. I think the mean was 3.6 sessions per participant for this attention bias modification training while they were going through basic training. Did you look at how long the effects of these training sessions would endure, or is that something that's going to have to require further research?
That's a great question. So regarding the clinical effect, we know how much it endured a year after. So our examination of the clinical effects was done 1 year after they finished the training. And during this year, obviously, they had, as you can see in the paper, they had their fair share, unfortunately, of combat exposure. I always said to the soldiers that I would be thrilled if my study would flop because they didn't have any exposure, but unfortunately, that wasn't the case. So we examined a year after. I will say that the previous study that we replicated and extended, there was a gap of 14 months, so a little longer than ours. Beyond that, there would need to be further research to see. And that's something that we also stated as a limitation, that we think that further studies should try to do it also longitudinally and check if these effects continue to be present down the road after multiple deployments, stuff like that.
Well, speaking of limitations, what were the limitations of your study?
So that's one of them. Unfortunately, the lack of long-term follow-up restricts our ability to make any conclusions about the sustainability of the protective effect over time and multiple deployments, like I said. Another thing is that we relied on self-report, completely on self-report. So soldiers completed what's called the PCL-5, a self-report questionnaire about post-trauma symptoms according to the DSM-5. And obviously, it would have been ideal to also use clinical interviews. But with the amount of soldiers that we had, it wasn't a possibility. And the last thing I'll say is that because of the nature and the context of our study, all the soldiers were together in their training program. So they had constant interaction with one another throughout the time that they were participating in our study. Something that we couldn't avoid, that's something that we couldn't control. And it is something that we have to keep in mind when we look at our results, that there could be a possibility that the assignment of one participant indirectly influenced outcomes of another.
So, are there immediate clinical implications either for the general public or for military organizations for your research?
Absolutely. Our findings suggest that the RT, the response time based, offers a potential for widespread implementation in military training programs. I will say that because of the moderate effect sizes, we advise that it should be used together as an integrated part of more of a comprehensive preventive tool in some sort of resilience building framework. But we know actually that the Israeli military already started implementing it at the beginning of the war. They created an internet-based version of that could be done on the phone, so that they were able to, send it widespread to soldiers before they went into combat. So we know already that it can be used. We hope that it will be unnecessary, and that if necessary, that it will help. And beyond soldiers, it could potentially also be relevant to first responders like police officers, firefighters. But obviously, we would need further research to look at that as well. But who knows?
And speaking of further research, what's next for your research?
So our group is still interested in continuing to examine the underlying mechanisms, also neuroimaging of PTSD, somehow to allow us to improve the efficacy of other PTSD treatments and hopefully other means of prevention like we examined here. I'll add a little plug without spoiling too much that we recently completed another RCT examining these ABM paradigms as an intervention for treatment intervention for veterans with PTSD. We're currently working on our paper for submission, so look out for that. But that's where our research is headed now.
Well, Chelsea, thank you for taking the time to speak with us today.
Thank you very much.
Up next, Dr. Ned Kalin. Dr. Kalin, welcome back to AJP Audio for March 2026.
Thank you, Aaron. It's a pleasure to be here.
This month on the podcast, I spoke with Dyan Gober Dykan regarding a trial looking at attention bias modification in the prevention of PTSD development in a cohort of combat-bound soldiers. What can you tell us about it?
Aaron, this is a really interesting study, and it has implications for thinking about new treatments for post-traumatic stress disorder. It's a study that was done in Israeli soldiers that were training to go into combat prior to combat. And it used a method that has been previously used in smaller samples that showed promise, which is called attention bias modification. The whole idea here is that engaging with threatening scenes or stimuli may be useful in processing them later on. The tendency frequency is to turn away, avoid, or try to suppress some really bad things that you see in your environment. And the idea here is that by engaging and paying attention to those stimuli, that may be helpful. And what this study does is it prospectively uses this treatment called attention bias modification to test whether or not it's better than another form of attention bias modification, and I'll get into the details, versus a sham or a sort of a fake attention bias response. So this study involved 501 male Israeli Defense Force recruits that were later going to go into combat. They were randomized to receive one of these three treatments that I told you about. One is what's called reaction time-based attention bias modification. And that's basically what used in the dot probe task, which I won't go into details, but it has to do with how fast you can respond. And that's sort of what the rewarding process of it is, to looking towards a threatening stimulus. So training individuals to pay attention to something that's threatening. The next attention bias modification is using eye tracking, to use your eyes to basically look at the stimulus instead of using the reaction time method. And this is also rewarded with playing music when you look at the more threatening stimulus. And then finally, there's the sham condition that just is some type of training that doesn't have to do with these specific mechanisms. They did this, and it was a relatively short computer-based treatment that was basically 4 sessions over 3 months. The individuals were then tested again when they came back from combat to see their PTSD symptoms and whether or not they had PTSD. And it turns out that the reaction time-based ABM, or attention bias modification pre-treatment prior to combat, actually significantly reduced PTSD symptoms and supposed PTSD illness. And the reason I say supposed is because these were self-reported symptoms, which is one of the issues with this study. This was not seen in the other attention bias modification approach, which used eye tracking and also music rewards, and it certainly wasn't seen in the sham group. Now, this holds promise, but one of the measures that we use in psychiatry or across medicine when we have a study is ask the question about how many individuals do you have to treat to actually get a positive response. And in this case, it's roughly 22 individuals numbers needed to treat. What that suggests is that this is not a strong effect. Mm-hmm. So it's a significant effect, but it's not really a very strong effect. However, this has great promise from the standpoint of thinking about how to modify this type of training, changing the dose response, how many times it's done, and so on and so forth. There's a really excellent editorial that's included by Dr. Barbara Rothbaum and Alex Rothbaum. Both are Emory University, and Dr. Rothbaum is an expert, probably the leading expert in the treatment of PTSD with psychotherapy. So she comments on this and other efforts that are ongoing now aimed at preventing the development of PTSD.
Next, we have a paper from Kaul and colleagues looking at an open-label extension trial on the long-term safety and efficacy of the recently approved xanomeline and trospium chloride in the treatment of schizophrenia.
So we have talked about this before. This is a new medication that was approved by the FDA in 2024 for the treatment of schizophrenia. And what's important to note about this medicine is that it doesn't work through the usual D2 blockade mechanisms. It has low or no effects in that system, but it does affect the cholinergic and the muscarinic system. And the active ingredient of this is a xanomeline, which is a M1 and M4 muscarinic receptor agonist. And these types of approaches have been thought of in the past, but they haven't been successful because of all the side effects. So when you enhance the cholinergic system, you have things like diarrhea, frequent urination, salivation, stomach upset, and stuff like that. What's clever about this drug development was that this xanomeline was combined with trospium, which is a drug that blocks the effects of this muscarinic agonism in the periphery and not in the brain. So the idea is that you can activate muscarinic receptors in the brain, but you don't have to have activation in the periphery and have all the side effects associated with it because you're giving a drug that blocks the muscarinic receptor. So this is the short term for this is called XT. As I mentioned, it was approved by the FDA in 2024. And there were 2 positive phase 3 trials that were performed that demonstrated that this was effective in reducing psychotic symptoms using the positive and negative syndrome scale, which is the common scale, and also some negative symptoms as well. So that's what basically led to the approval of this novel mechanism antipsychotic acting drug. What we're looking at here is an open label study following up the individuals that were in the 2 clinical trial phase 3 shorter term studies, giving them all an opportunity, even those that were on placebo, to now take the active drug. And in this open label study, the idea was to follow these individuals for a year and to see what kind of side effects emerged. Was it anything new? Did it continue to look relatively safe? And also, was it effective in the long term? And so this is a really interesting study. The dose that was used was titrating up the dose of XT to 125 milligrams of xanomeline and 30 milligrams of trospium twice a day. Primary endpoint was, again, emergent adverse events, as well as looking at efficacy. There were 366 patients that completed the 5-week trials, and of them, 156, roughly half or a little less than half, enrolled in the long-term study. And of those, only 152 had at least 1 dose. So 4 basically dropped out. And then when they looked at the analysis, they looked at anybody that had at least 1 dose, and also they completed the baseline scales. And that then came out to 111 individuals. The reason I'm telling you all this is because the initial sample that was enrolled dropped quite a bit from the standpoint of those that actually were completed in the analysis. And at the end of the study, only a small number, 35 individuals, actually completed the whole study. So it's important to keep that in mind as we talk about the data because it's a relatively low sample. And what they found was that the same types of side effects that were noticed in the acute studies were noticed also in this long-term study. These are mostly GI side effects and effects related to nausea, dyspepsia, some vomiting, some dry mouth. Mm-hmm. These tended to occur in the first 5 weeks or so of the study early on and then tended to either diminish or just stay the same. There were no significant changes in weight that were observed and no changes in glucose or body or prolactin levels. And that's all good news because those are things that frequently happen with long-term use of most of our second-generation antipsychotics. However, I will note that, again, only a small number of individuals actually completed the study over the long term. So it looks like the drug, from these data continues to look good as far as adverse side effects go. It looks good also perhaps from the standpoint of not having some of the metabolic effects that we see with many of the antipsychotics, although again, I think right now I would take that with a grain of salt because it was only in a few patients, relatively small number of patients that had the long-term data. And we have an expert in drug development and clinical trials for schizophrenia, Dr. Donald Golf from NYU, gives an editorial, and he talks about, the next step is thinking about how we can use these two distinctly different mechanisms, one working on agonizing or in activating the M4 and M1 receptors, and the other, the more traditional D2 receptor mechanisms. Can we begin to find patients that are more selectively responsive to these different types of approaches from the standpoint of the mechanism? And will that take us a step closer to a more personalized approach in schizophrenia? And that's sort of the issue that Dr. Goff addresses.
And finally, we have a paper from Kantrowitz and colleagues with an interesting look at the effects of the mechanisms of clinical trials themselves, a meta-analysis and meta-regression of effect size deflation and sample size adjustment in large trials looking at negative symptoms of schizophrenia.
This is, I think, an important study, and it basically confirms what I think many people either knew or expected in relation to clinical trials. And I think that it's specifically related to clinical trials trying to find drugs that are effective for the negative symptoms of schizophrenia. But there are lessons learned here, I think, for all clinical trials, and maybe not surprises, but again, the science confirming what people have thought. So first, let me just say a few words about how difficult negative symptoms are to treat. These, of course, are the symptoms that schizophrenic patients have that are related mostly to their decrease in functioning. These include things like having blunted emotion or affect, not being interested in things in the environment, anhedonia, not being having a lot, feeling like there's going on in their heads and not saying a lot, not being particularly motivated, not interested in social interactions, and those types of things. And you can see how that cluster of symptoms, if persistent, could really erode someone's ability to function in the world and to have positive relationships and social relationships. So it's clearly been demonstrated that these symptoms are fundamentally important to the severe decrement in functioning that schizophrenics deal with. So, of course, there's been a quest to come up with medicines that will help these symptoms. And in general, our traditional antipsychotics have not been particularly helpful for treating these symptoms. They're very good at the acute positive symptoms, the psychotic symptoms that are hallucinations and delusions and confusion and thinking and things like that. But they're not really good at these symptoms. There have been a lot of studies that have tried to tackle this, and one of the observations that the authors make is that the smaller studies that are done tend to have positive effects of the drugs that are studied. But when these drugs get into larger phase 2 or larger phase 3 clinical trials, they tend to fail or the results are more inconsistent. And that's why these drugs haven't come to market. So the question is, why is that? And what these authors did is they looked at the whole literature. They found 159 studies that were aimed at treating negative symptoms in schizophrenic individuals that did not have acute, symptoms at that point. And these were studies also where a new drug was added on to the ongoing antipsychotic treatment that the patient was getting. And they also had to compare that drug to a placebo. So that were the criteria that underpinned the 159 studies that were selected. And basically, when they looked at this, there were roughly 13,000 individuals that participated in these studies, so a huge number. And about half of the studies were done in multiple sites, not just at one site. And also what was interesting is, as you would imagine, these 159 studies tried different medicines, and the different medicines could be basically subdivided into different classes. And so one of the other questions that they looked at was, were the different ways that these medicines work, the different mechanisms of action, were any of them seem to be more significantly effective for negative symptoms than the others? The first question they asked was around these different medicines. They found from the meta-analysis that there were 4 mechanisms of action that appeared to have significant effects on reducing negative symptoms when they looked at all these studies compared to placebo. The greatest effect was found for a serotonin 3 receptor antagonist. And this is really interesting because the drug ondansetron, which you may have heard of, is a drug that is typically used for nausea, an anti-nausea agent. It's very effective, and it works through the 5-HT3 receptor blockade. That type of mechanism looked to be effective. Also, what appeared to be effective were drugs that affect the glutamate neurotransmitter or modulated the glutamate receptors, the NMDA receptors. Some anti-inflammatory drugs looked positive, and also antidepressants looked positive. Now, there were not significant effects for a number of other types of mechanisms of action that have been tried, including drugs that affected the estrogen system, drugs that inhibited acetylcholinesterase. Those are drugs that are used, for example, in neurodegenerative memory types of problems, dopaminergic agents, and also agents that hit the nicotinic receptor, the alpha-7 nicotinic receptor. So that's important information about the 4 classes of drugs that may be effective. Now, when they looked at all of these studies and they asked the question, what variables may have affected the outcomes in addition to the drugs, what they found was that there were 2 things that stood out. One was the sample size, and the other was the number of study sites that were in these studies. And what they found was that the more study sites and the bigger the study, the more individuals that were in it, the less likely there was a positive effect of the drug that was found. But what was interesting about this, the impact of the large number of study sites with the large samples was that it really increased the likelihood of placebo-treated individuals to look like they're responding. So in other words, a higher placebo response rate. So, this is really interesting. It's important. And what they found more specifically, that studies that had greater than 20 participants per site were more likely to show real positive effects. So if you had a lot of sites with small numbers in each site, you're more likely to have a big placebo response and therefore not be able to just differentiate that from your active drug. So this is important information, obviously, in designing clinical trials. And again, another expert in schizophrenia trials, Dr. Stephen Marder from UCLA, contributed an editorial that talked about ways to overcome this issue in clinical trials, and really also brought home the point of the need for more research aimed at reducing negative symptoms in individuals suffering from schizophrenia.
Well, Dr. Kalin, thank you once again for taking the time to speak with us.
You're welcome. It's always a pleasure, Aaron.
That's all for this month's episode of AJP Audio, but I hope you'll be with us once again in April, when we'll again bring you the best research psychiatry has to offer.
The views and opinions expressed in this podcast are those of the individual speakers only, and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only, and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.